Alright guys, in this short video we are quickly going to discuss about amblyopia. Now amblyopia is stimulus deprived loss of vision. Yes. Now don't confuse amblyopia with that of amaurosis. Now amaurosis is when there is any systemic infection, maybe with streptococcus, or there is acute nephritis. The toxins start circulating in the body and they actually have its effect on the visual pathways and they cause temporary loss of vision which may be complete. So the patient may complain of curtain falling from above, curtain falling from below, and the patient will have sudden onset and the patient will recover in normally 10 to 18 hours. The recovery starts and the recovery is completed by 48 hours. That is amaurosis. So amblyopia is partial loss of vision, more specifically the 2 to 3 lines on the Snellen's chart. So normal vision is 6/6. So the line which is above 6/6 is 6/9. The line which is even above by 6/9 is 6/12. So the patient's vision may be 6/18, 6/12, 6/9. Yes, the normal is 6/6. So it is partial loss of vision. In amaurosis, there is complete loss of vision and it is short-lived. There is recovery. Yes, and also there is another term which is amaurosis fugax. What is difference between amaurosis and amaurosis fugax? So amaurosis, so there is sudden acute loss of vision and curtain falling in front of the eyes, but the examination of the fundus will be normal. In amblyopia as well, ophthalmoscopically the fundus examination is normal. In amaurosis the fundus examination is normal. I told you na, it is the effect of toxins on the visual function, on the visual receptors. Yes, and yes, now amaurosis fugax is that there is some embolus which is circulating in the blood. So when it will come and it will occlude the blood supply, there will be the response which will be sudden painless loss of vision. It will be there and then, and it will be removed in just few minutes. The embolus will move on and the patient will regain the vision. So what is the difference between amaurosis and amaurosis fugax? So amaurosis fugax gets fine within few minutes, number one. And in amaurosis fugax, because there was embolus which was circulating in the retina, yes, so there may be retinal hemorrhages, there may be retinal edema which may happen, there may be disc edema. Yes, but in amaurosis you don't see any ophthalmoscopic changes. Yes, okay. Now coming on to amblyopia, I told you it is stimulus deprived loss of vision. What are the causes of amblyopia? The most common cause is anisometropia. Anisometropia is a condition when there is difference in the refractive error of two eyes. It can be as less as 1 diopter, but the significant anisometropia is, it is your previous year question, significant is when it is more than equal to 2.5 diopter. Yes, number one. Second, it may be congenital cataract, then it may be due to strabismus or squint. That means one eye is taking the fixation, another eye is not taking the fixation. So one eye fovea is being stimulated, another eye the fovea is not being stimulated. Now two fovea are corresponding points on the retina. You know, when two corresponding points on the retina are stimulated together, only then the image will be fused. But when two non-corresponding points on the retina are being stimulated, the image will not be fused and the patient will have diplopia. So what the brain does, brain suppresses the image of the deviating eye, of the non-fixating eye, of the eye on which the light is falling on the non-corresponding point. Yes, so squint. Then fourth, we can have mechanical cause. Mechanical means there is drooping of the eyelid, which is your ptosis. Yes, so these are the important causes of amblyopia. Now, what will be the management? The management depends upon the age of the child. Now, theoretically, you can treat amblyopia by 7 to 8 years of age. This is also your previous year question. But practically, it is seen that you can treat amblyopia by 13 to 14 years of age. Now, more is the age, more aggressive is the treatment, because as the age progresses, the amblyopia becomes difficult to treat. If the age of the child is say 1 year, so you go on for 1:1 occlusion therapy. If the age of the child is 2 years, so you go for 1:2 occlusion therapy. If it is 3 years, 1:3. If it is 4 years, it is 1:4, and so on. Now, what do you understand by 1:1, 1:2, 1:3, 1:4? That means, let's take this. So 3 years, 1:3 means 1 day you cover the abnormal eye, but 3 days you cover the normal eye. That means you are trying to stimulate abnormal eye or here amblyopic eye for 3 days. And now you will say, sir, what is the purpose of this? The simple purpose is, once you are going to cover the normal eye, you are forcing the brain to use amblyopic eye. That is going to increase the vision of the patient. Yes, if the age is 4 years, so you need even more aggressive therapy. So you are going to cover or patch the normal eye for 4 days. And you are going to patch the 5th day, you are going to patch the abnormal eye. Why you are going to patch the abnormal eye? Because of course, if you will keep the normal eye patched for a long duration of time, the amblyopic eye will get better in less time. But the eye which is patched, which is, my dear friend, the normal eye, the sound eye, it will go into amblyopia. So you have to keep stimulating both the eyes, but you have to stimulate the amblyopic eye more. Have you got this? So this is one way by which you can treat amblyopia. Second way is, sometimes for children it becomes difficult to keep one eye patched for the entire day, and you will have to keep other eye patched on different days the entire day. Yes, so you actually can go on for intermittent patching. So most of the doctors go on for intermittent patching. Here what you do, so you have to patch the normal eye for 6 to 8 or 8 to 10 hours a day, depending upon the extent of amblyopia, and rest of the time you simply remove the patch. It is really well acceptable to the child as well as to the parent. But please understand, once you are going on for occlusion, you will have to first treat the underlying cause. If the patient is having cataract, you will have to operate upon the patient. If the patient is having an anisometropia, you have to treat the anisometropia. That means refractive error. Yes. If the patient is having squint, you will have to perform squint surgery. If the patient is having ptosis, you have to perform the ptosis correction surgery. Yes. After that, you will go on for occlusion therapy. Let that be the full occlusion therapy, 1:1, 1:2, 1:3, or you have to go on for intermittent patching. Third is penalization. Penalization is the basic idea of the treatment is, you want to stimulate the amblyopic eye. So you put atropine eye drops. Atropine is a mydriatic agent. Since it is a mydriatic agent, it is going to dilate the pupil. When the pupil is dilated, you know, after dilatation there will be blurring. So if you will put atropine in the normal eye, so normal eye will have a blurred vision. The brain will force to use the amblyopic eye. So that actually results in the treatment. If the child is not very well compliant to the patching, जो छोटे बच्चे होते हैं, you put up a patch, send the child to school, and when the child will come, you will see that the patch has been removed, and the child would say, मम्मी मम्मी मुझे सारे छेड़ रहे थे, मम्मी मम्मी मुझे अच्छा नहीं लग रहा था, मम्मी मम्मी मुझे खारिश हो रही थी यहाँ पे. It is like this. So some children are not much compliant to patching, so in those cases you can go on for penalization. Yes, so that is the treatment of amblyopia. Now I want to give you one extra point. Have you ever heard of something known as crowding phenomena? This is an extra point, more important for your INI-CT, so you have to write it in the box. This phenomenon is when you will ask the patient to read the letters in a line on Snellen's chart, because the letters are placed like M, X, O side by side now. So the patient will not be able to read it because the letters are arranged in a continuity. But when you will ask the patient to read the letters individually, the patient will be able to read it. Crowding phenomenon is patient is not able to read the letters in continuity on Snellen's chart. Yes, so that is your crowding phenomena. And there is also, in amblyopia, there is also loss of contrast sensitivity. Loss of contrast sensitivity. These are two important points I wanted to give you if you are focusing on your INI-CT exam. But yes, everything that I have told you so far is important with the purpose of FMG, NEET PG and INI-CT. Let me know how you like the video, and I'll be getting back with some more informative videos. Best wishes from my side.